Yeah, Assalamualaikum warahmatullahi wabarakatuh. Good evening, everyone. So my name is Nazmi. I will be the chairman and MC for today's CME session on behalf of Prof. Dr. Adinina, because she is currently attending another meeting. So I would like to take this opportunity to welcome Prof. Siza Abdul Manaf, our Deputy Dean of Medicine, and also fellow colleagues, and also the online audience. Without further ado, let me introduce the two speakers for today. The first one is Ala Ahmad Al-Shah, a PhD student in HSM and UPM. His topic is on optimizing training system to drive excellence in public health. His session will be via Zoom today because he's currently overseas. And the second speaker is Muhammad Irfan Edros, a PhD student in UPM. He will be sharing his experience regarding international seminar on healthcare financing at the Universitas Muhammadiyah Kalimantan Timur in Indonesia. So for everyone's information, the Q&A session will be after the second speaker's presentation, but feel free to leave the question anytime in the chat box, and don't forget to indicate which speaker you're referring to in your question, okay? So I would like to invite the first speaker, Ala Ahmad Ashraf, for his presentation. Please give him a big round of applause.
Just to make sure, Nazmi, is the presentation in full screen mode?
Yes, we can see it clearly. Thank you.
Yes. Excellent, thank you. بسم الله والصلاة والسلام على رسول الله. رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. Good afternoon, everybody. It's a pleasure to be here today with you, all sharing a common goal of advancing public health in general. In a world where the challenges are becoming increasingly complex and interconnected, the role of fully trained public health workforce is critical. And today we can explore strategies and also methodologies for optimizing training system to drive excellence in public health in today's session. To start with, esteemed colleagues and participants, I will pose these questions. Can public health system function without a workforce? Of course, the simple answer for this question, it cannot only function without a workforce. Usually we are referring to a public health workforce. Public health system depend on their availability, competence, and quality. And we are highlighting three major elements related to the public health workforce: their availability in adequate numbers, and also their competence with regard to the knowledge, skills, and relevant attitude to the public health, and also the quality. Most of the workforce related to the health suffering from low quality human resource available at the national level usually. Today, we are aiming in this session to tackle three major objectives. To highlight first the critical role of training within public health organization and emphasize its significant in fostering professional development, improve performance, and ultimately enhance organization effectiveness. And also we will tackle the point related to the strategies and method to optimize the training activities and to provide a practical example for successful training initiatives at the international level accordingly. In the introduction, as I stated before, the workforce has been regarded as one of the healthcare system's most valuable asset and essential building block. Also, the WHO regard human capital as one of the major six pillar of the healthcare system. To meet the growing demand, the healthcare sector will require many new and reskilled health workforce. This is a report recently published by the WHO. By 2030, the healthcare sector will face a shortage of 18 million healthcare workforce or worker globally, and the most shortage in the low and middle income countries. It's predicted that almost more than 375 million workers of the global work will need to be reskilled or upskilled by 2030. To highlight these two terms, reskill is introducing a new knowledge or skills to the workforce in order to advance their current career. However, upskilling is also in the similar context. Also, in this presentation, we are tackling the public health workforce. Training the workforce that deliver the public health functions is a key element to ensure the development of capable, competent workforce at the national level accordingly. The WHO has proposed almost 12 global relevant essential public health functions. It is the responsibility of the public workforce to deliver these functions and implemented usually by government departments and various sectors to bridge gap and improve the health system resilience in general. These are the listed 12 functions proposed by the WHO, whether it is emergency management, public health stewardship, health protection, disease prevention, promotion, and etc. Also, within the context of this presentation, we are referring to the public health workforce, to the all individual who contribute to the delivery of at least one of the public health function stated in the previous slide of the integrated service and system. And almost the WHO categorized these personnel or individual to three major category or groups. We have the first group, the core public health personnel, such as epidemiologists, public health researchers, public health managers. And we have also the second group, which is the health and care worker, physicians, nurses, pharmacists. And we have also the occupational aligned to health, which is the group number 3, similar to the personnel responsible for water sanitations, food supply, and etc. Identifying the skills and the competences required is effective means for preparing the workforce to deliver the essential public health functions. Emphasizing outcome-oriented learning and tailored teaching, it is also critical and crucial. Also, in the same context, the WHO in the 2024 released the competency framework for public healthcare workforce. It includes almost 7 competency domains with also a number of subdomains under each main domain. Taking these in considerations in guiding our efforts in training and developing our public health workforce is very crucial and very important. Who is responsible for public health workforce training and development? It is all the organization, individual themselves, the government, education institution, and also professional association and union. However, in a recent study about the state of training in the healthcare systems, most of the respondents claim that the organizations or the public healthcare organization is the main responsible for the workforce trainings. We have different types of training. We have training, which is the formal or official training that is almostly provided by the organization. We have some other form of professional development, such as self-directed learning and continuous education hours, whether it is initiated by individual, government, and also professional association union. However, we are talking today in the context of the training that is almostly formal and provided by the organization themselves in order to train and develop the capability of their public health workforce accordingly. Public health training program in the context of our presentation is a foundation for the health workforce. This program is designed to equip professionals with the knowledge, skills, and also attitude necessary to address a wide range of public health competences, from disease prevention to health promotion, and also emergency response and policy development as well. In this also context, there is disruptive forces or trends affecting both the public health system in general and also the education or the training system, such as advancing in the public health knowledge and sciences, new technology, fast changing demographics. People currently are more better educated, informatics and big data analytics, resource constraints. However, these disruptive forces affecting, as I stated before, both the training system and also the public health system in general. For example, in the new technology, the training currently is integrating technology in education, AI, massive open online training methodology, virtual tutors, and etc. And also in the public health systems, the new technology related to the early disease preventions, immunization, and etc. also affecting the public health system in general. The critical role of training within public health organization, it is vital in maintaining the competency of the public health workforce, given the fact we are experiencing a rapid era of changes again affecting the public health system and also the training system. In today's rapidly changing environment, public healthcare professionals are continually developing their knowledge skills to meet the need of their community. Maximizing the impact of public health training and development opportunity help ensure the great return on the limited resources available for professional development. And this is the main point that we will emphasize during this session accordingly. The need for optimization. The current public healthcare professional training and development system faces significant challenges, and also most of the literature says these challenges is about the outdated content provided to the public healthcare professional, the lack of standardization among these training programs, poor technology integrations, along with other challenging. Optimizing these systems is crucial to ensure the next generation of public healthcare professionals is equipped to address emerging threat and drive sustainable improvement in population well-being accordingly. What is the benefit of optimizing training system? Optimizing the public health training system can yield significant advantage, including enhancing competency, improve outcome, great workforce resilience. However, these benefits can be categorized to individual benefits and also organizational and national benefits. Organizational benefit, improving performance, efficiency, effectiveness, productivity. Also at the individual level, improving competences, motivation, retention. At the national level, also enhancing the disease prevention and control, improve health promotion and education, ensure emergency response, enhance the outcome of the overall public healthcare system in general. In today's session, we will tackle a number of pillars with regard to the optimizing training system. Designing an effective and impactful training and development system for the public healthcare workforce require focusing on almost 5 key pillars. These pillars already published by the Public Health Foundation, and most of the material presented this session are taken from the Public Health Foundation optimization strategy for a training system. The first area we are tackling today is the assessment. And also it is an overlooked area usually in most of the training and development initiatives. Assessing training need and the resources available to meet those needs form the first pillar in developing and delivering an effective training and development system. Strategies and method in this section address factors related to the learner, to the organization, trainers, and also the environment where the actual training efforts will happen accordingly. We're tackling this in 5 key strategies area. We have the general area. When beginning to collect assessment information to guide the development and delivery of training, it's important to consider the need of the training first. Identifying the need, understand whether there is a real need for training, will prevent unnecessary initiatives. Again, the aim is to optimize, is not to produce more training and developments. So identifying the actual need for the training is the first pillar or the first step. For a resource optimization purposes, ensuring that the investment in the training yield a benefit outcomes, and these outcomes not wasted, and also linked to a specific need identified. Training developed in the response to the clear need is more likely to improve performance and achieve desired outcomes. So in general, the first step in launching any capacity building initiative or opportunity for a public health workforce is to identify the actual needs. In addition to these actual needs, there is other factors or elements should be taken in consideration in the assessment phase. These factors also categorized to 4 main categories. The first one is related to the learner themselves. Again, during my search in the previous literatures, this area almostly overlooked in the literatures, which is the factor related to the learner themselves participating in the training. Conducting an assessment to identify these factors is very important and foundational to the effective training. Determine relevant characteristics of the participants, such as their current competencies, preferred training modes, learning style, culture, and language. It is very crucial and very important in order to design an effective training programs or development programs in general. In a recent study published in Saudi Arabia about the main challenges or barrier to engage healthcare professional in health research, it was very tiny things. Actually, it was the language. Most of the training delivered with regard to the health research was in English language. However, the national language is the Arabic language. So healthcare professional found themselves unable to attend this actually training session because it was in a second language, which is the English language. So sometimes determining the relevant characteristics of the audience or the participants, their current competence is very important. Similarly, also their preferred training modes, their preferred learning style also, it's very crucial. Also, assessing the motivation of the learner, whether it is internal and external, it's very important. And meeting these also motivators, it's very crucial. However, also one of the pillars for optimizing the training system is motivating the learning, and we'll address this point in details in the upcoming slides. Also, assessing the likely time potential learning have available for training, it's very also crucial. And also the personal resources in terms of time, efforts, and availability for the healthcare, the public healthcare professionals, also very important and essential building block for developing any training and development initiatives. Similarly, also we have a set of organizational factors in which training take place. That might affect also the process of the training, such as the actual mission, the strategic goal, policy, culture, and the structures, and the supervisor of the institution themselves. Contextualizing the trainings to a specific context or to a specific organization is very important. Providing a more generic training that tackle whatever the organization is, it's a bit risky, and it might also not linked directly to the organizational mission, goals and objectives, and not being tailored to the culture, to the policies, to the structures, and also to the way of doing things within the organization themselves. Also, determining the organization needs, goals, and also readiness for the new knowledge and the skills is very crucial and important. However, some training and development initiative that introduce new knowledge and the skills fail to be implemented on the ground because the organization is not ready actually for this new knowledge on the skills from the learner. And also, it's very crucial in the early stage to assess the available resources directed to the training and the development of the public health workforce, such as the human, financial, environmental, and technological resources available within the organization themselves. However, some organizations have dedicated departments or entity responsible for the continuous development and the training of the public healthcare workforce. And also, similarly, they have financial resources, environment in terms of room setups, and also structures, technologies such as learning management systems and other online resources, and etc. Similarly, also, there is also some other factors need to be assessed prior to start any training and development initiatives, which is the trainers or the facilitator themselves. These trainer and facilitator, they should have to be a subject matter expert. We have to determine their skills, knowledge, competences, and these knowledge, skills, and competences should be relevant to the topics introduced in the training itself, and also their personal qualifications and the quality. It's very important, such as passion, flexibility, adaptability, in addition to the technical skills and related to the training and development. However, being a subject matter expert not necessarily mean that you will deliver a successful training and development session or initiatives. Again, the technical skills with regard to the actual training methodologies, such as adult learning principle, active learning techniques, and the ability to choose the most appropriate approach specific to the learning objective. There is a technicality within the training industry needed to be there for any facilitator or trainers, crafting the outcomes for the sessions, choosing and adopting a specific delivery methodology, utilizing assessment methodologies, and also evaluating the outcomes of the sessions. These are technicalities within the training industry that any trainers or facilitator need to have prior to delivering any training initiatives accordingly. The final set of factors also that needed to be assessed prior to any training initiatives is the environment, which is the external environment where the actual organization actively engaged in delivering public health services, such as the politics, the economics, the social health, the public health system in general, and also the overall support toward enablement for the public healthcare functions within the country itself. Also, assess the environment in which the learner will learn, such as the physical environment, noise level, electricity, lighting, and technology capability, and also assessing the organizational support provided to the learner, such as the encouragement from the management, the environment supportive for knowledge transfer, and applying the acquired knowledge and the skills after the training accordingly. This is the first pillar, actually, in delivering any training and development opportunity directed to improve the capability of the public healthcare workforce. The second pillar, which is the motivation, motivating the participants to participate, engage, and interact with the training is key to the successful training effort. Motivation not limited actually to the trainer or to the learners. Also, the trainers need to be motivated, the supervisors, the people and the peer within the organization themselves also need to be motivated. We will tackle these three major categories in separations. First, we need to motivate the learner. We need to provide, whether it is external or internal motivators, external such as education hours, recognized training completions such as certifications, rewards, and also we need to fulfill internal motivators such as professional development, autonomy, opportunity for networking and interactions. And also one of the important elements in motivating learning to engage and interact with the training is making the training more accessible, affordable, identify these opportunities, publish these opportunities, and make these opportunities more available and also flexible to attain different learner needs and desire accordingly. Similarly, also, we need to motivate the trainers themselves. Trainer motivation and engagement can heavily influence training effectiveness. Actually, they are the one who deliver the outcome of the training sessions or the initiatives. So their motivations and engagement with the training is very crucial and very important. So we need to provide the support. We need to explicitly and realistically articulate specific objectives and also guide the trainer or the facilitators with regard to the method for delivering particular training sessions or training interventions. And also we need to provide tips and support in training logistics and also in designing the actual training and also proposing specific assessment and also evaluation, offer feedback to the trainer themselves in order to recognize also training excellence and shortcoming in the training intervention accordingly. Also, we need to motivate the supervisors. Why we need to motivate the supervisors? Actually, the training not actually terminated after the training itself. Actually, the learners or the public healthcare worker need to take whatever new knowledge and the skills learned during a specific training session to the actual workplace. So motivating supervisors to provide the support for the learning and provide opportunity for them to apply their new skills and competences by recognizing supervisor for the learner attainment and also demonstrating the value of implementing outcome of the training and aligning these training with the strategic goals of the department or the organization itself, and incorporating these new skills in the performance metric and the review, and linking these actual training topics to the public health and other professional competences or standards. The second pillar in optimizing also the training system is the design. Actually, a well-designed training or development opportunities or initiative should be planned, appropriate to the target audience, and can deliver within the available resources accordingly. Strategies and method in this section address planning for a training, developing the training material, and providing training and crafting a strategy for actually evaluating the outcomes of the training itself. Planning the training, actually, the design of an effective training begin with a plan. Developing a training plan that is tailored to the audience and the resources available. These plans should articulate and outline a roadmap for developing and delivering the related training, and also identify the desired outcomes and aligning this training initiative with the organization needs, goals, objective, and also with the wider environment, which is the public healthcare system in general. Tailor this training to the audience and the resources available. Again, some organization or institution suffer from resources constraints, so tailoring this training to the available resources is also very important. Incorporating adult learning principles and problem-based learning method also, and selecting appropriate training format, learning strategies, technology, also it's very crucial in the design stage. And also developing and implement a market plan that specifically communicates clearly the available training opportunities to the public healthcare workforce is very crucial and very important. Actually, we have a lack of a platform that communicate the available competency building opportunities or training sessions available for the public healthcare workforce. So working hardly in developing and implementing a marketing plan, whether it is internally, if we are targeting our employee, or externally to the public, to the general public health workforce, is very important and crucial, and also should be considered in the design stage. Also, in the design stage, we need to draft and craft the material for the training session or the training interventions. The engagement with the training activity is very crucial and very important, by utilizing various method techniques to enhance the retention of learning, such as case studies, problem-based learning, and other techniques and methods, considering the existing education resources, such as already articulated the training plan, and developing the actual learning materials such as slide, exercise, and activities, and also the test and the quizzes. It's very crucial in this stage. Finally, in the design stage, and also it is very crucial elements. Sometimes most of the training and development interventions look to the evaluation after the actual training or the session. However, we are emphasizing here that the evaluation of the training outcome should be considered in the design phase. The most effective evaluation is not initiated after the training session, but occur throughout the training process, and also should be planned prior to the actual training. And this evaluation should align with the actual needs or the outcomes of the actual training interventions, and also should match these competencies outcome, and also design around the actual program objectives. And also we'll tackle elements of the evaluation within this presentation while we are tackling the evaluation pillar in optimizing the training system. The third pillar for optimizing the training system is the delivery. Here we will articulate strategies and method in these sections to facilitate the interaction effectively with the content, and to actually facilitate the retain and apply of the delivered knowledge, skills, and competences to the public healthcare workers. For illustrations, we have different delivery methodology, and every delivery method have its own characteristics and also elements related to the delivery. We have in-person training, we have virtual online delivery, and we have a blended approach, a blended model. It is currently a wide integrated methodology of training for all healthcare professionals. In a recent research by the State of Healthcare Training in USA, they found blended approach the first delivery method currently for delivering whether it is public or non-public training session for healthcare professionals accordingly. In the delivery, also we have some element related to this delivery methodology. We need actually to communicate the actual learning goals or objective and outcomes to the learner, and help the learner see how the training relate to them, related training to the job or the job function, career development, and the previous real life experiences, and also implement active learning and provide opportunity for learner to participate and apply the training on the job, while offering also opportunity for interaction, reflection, and also informative feedback, and engage and solicit learning feedback throughout the training process, and utilize these feedbacks in order to continuously improve and enhance the actual delivery of the training, particularly if the training program lasts for more than, for example, 1 day or 2 days, and etc. The final pillar in optimizing the training system, which is the evaluation stage. The evaluation considers the success of the training, and it's necessary for identifying element of training process and the training program that were beneficial, and also the area for improvement. The most effective evaluation is not initiated following the end of the training. Actually, it can also occur within the training. There is two types of evaluation or assessment. Generally, we have a summative and formative assessment. This is with regard to the assessment, actually, and also the assessment is part of the evaluation. Summative, that is almostly happen at the end of the training. Formative, that also happen within the training itself, in order to adjust the way we are delivering the training to the audience, and make sure that we are delivering the needed competences accordingly. Plan the evaluation, it's very crucial, and also we have stated this in the design phase. However, the three areas to explore in the evaluation strategies and methods, and also there is a lot of models that tackle the evaluation of the training interventions, similar to the input, process, and outcome models. We have also Kirkpatrick model for evaluation, and also we have other model. In the process evaluation, it focuses on determining whether the elements involved in the training development and delivery was adequate and conducted. Actually, in conducting the process evaluation, we need actually to plan for the evaluation and define the key measures and indicators to evaluate, and choose the actual data analysis technique appropriate for the target audience, and design this evaluation appropriately. And we need also to collect both qualitative and quantitative data. We can collect numbers, figures, actual feedback, qualitative feedback from the participants. Again, the very important element of the evaluation is analyzing and make use of the data collected in the improvement and enhancement of the actual training intervention within the organization itself. It's very important and very crucial. The outcome, we are experiencing a momentum toward what we call outcome-based training and development activities or initiatives, where the outcomes, it's being emphasized rather than the actual time of the training or the overall arching objective of the training. The outcomes focus on the what learner had learned, or what the learner actually gained in terms of knowledge, skills, and attitude after the training actually happened. We have different level of training evaluation also for the outcomes. We can tackle level where we assess the reaction of the learners actually for the training. This is in form of qualitative or quantitative measurement data, such as satisfaction level, satisfaction scales, and comments for the overall reaction of the participant. Also, we can tackle and assess the learning, and it can be done through exams, such as pre, post, and delivering, for example, a capstone project accordingly. And also we can assess the behavior or the application of the knowledge itself gained during the training programs or the training initiative. This is require an extensive effort and collaboration from the managers and also the organization itself to follow up with the trainees and see the actual application of the new knowledge gained during a training. And also some literatures seek also to assess result at the organizational level, such as enhance patient satisfaction, enhance outreach for rural areas. This is in the context of public health system, enhance productivity, efficiency, and etc. And the final extensive also level for evaluation, which is the return on investment. This is involve an advanced economic analysis for the cost analysis engaged or involved in the actual delivery of the training. Collect these data with the appropriate methods, and also you need to determine the actual timing and the source for data collection based on the level at which the training is being evaluated, whether it is at the reaction learning or behavior or application level. And again, analyzing these data, it's very important and crucial, whether it is a descriptive statistical data or comments or performance reviews, if we are assessing the application of the actual knowledge, and also whether we are collecting metrics at the organizational level, such as customer satisfaction, employee retention in general. Again, a very important and also underutilized element in the evaluation of the training initiative is the reporting and take actions based on the collected evaluation result, and sharing this evaluation result with the appropriate audience or stakeholders is very crucial. And summarizing the result, the fact sheets, and reporting that can be also utilized using the learning management system is very crucial and important. Communication and make use of these evaluation data is very important and crucial. To illustrate, we have quickly, we are running out of time, two case study for success stories with regard to public health training initiative. The first initiative was actually launched by the CDC. It was the Field Epidemiology Training Program. It was a well-established initiative aimed at strengthening the capacity of the public health professional to detect and respond to the disease outbreaks. Again, it is initiated by the CDC in collaboration with the local governments. This initiative was run actually in over 70 countries. The program was structured in 2 years, competency-based training programs. Again, we are seeing a more focus on competencies and outcome-based training initiatives. Again, competency-based and outcome-based training initiatives, it's very crucial. This particular initiative, it was a competency-based training program that combines a classroom instruction with the field assignments. The trainer was known as fellows, participating in hands-on projects, outbreak investigation, and surveillance activities under the guidance of the mentor appointed by the program themselves. The actual key features and innovations in this particular initiative was the on-the-job training, or what they call apprenticeships. The fellows spend most of their time in the field applying their skills, real-world public healthcare problems. There was a mentorship for each fellow. Is there a mentor who is following him and follow with the requirements gathering regarding to the actual competencies delivered during the program. Also, the curriculum was tailored to a specific country's context. As stated before, any training initiative should take in consideration also the environmental factors that include also the country-specific public healthcare needs, cultures, language, and etc. The outcome of this program was tremendous. Actually, hundreds of epidemiologists was graduated, who was responsible for detecting and responding to a wide range of disease outbreaks, such as COVID-19 and also other disease outbreak hit in each country according. Similarly, also another case study with innovative training method utilization. Again, there is a prominent growth in the utilization of AR, VR. AR, we are referring to artificial intelligence or virtual reality VR in the training for emergency preparedness. This particular initiative was a response to a need for innovative training methods. A leading public healthcare institutions, without referring to its need, implement a virtual reality training program focused on emergency preparedness. The VR program aimed to provide a realistic, impressive training experience for public healthcare professionals involved in a disaster response. The program structure was structured around the participant engage in a VR simulations that replicate the various emergency scenarios such as natural disaster, infection disease outbreak, and any specific also bioterrorism events. The program include pre-stimulating briefing, real-time scenario navigations, and there was also a predefined learning outcome for each particular session. The key feature of innovation is, again, the integration of AR, VR technology in creating realistic environment where participants can practice their skills without the real-world risk. Interdisciplinary collaboration, where the program also was structures in collaboration with multiple sectors within the country themselves, and also the utilization of adaptive scenario. Personally, I get engaged in also a public training program in utilizing VR technologies to educate public healthcare worker on life-saving scenarios. We develop 3 courses for basic life supports and specific emergencies in VR context, and it was really a very successful initiative where people and healthcare professionals were very engaging to experience the VR and AR within the public health context or the healthcare context in general. Also, to highlight within the case studies presentation, the technology integration is very key and very important, leveraging cutting-edge technology, digital tools to enhance training delivery, data analysis, particularly if we are utilizing a learning management system, we can generate specific data analysis or data regarding to the engagement, to the completions, and also to the interactions with the actual training material. Launching virtual classroom, online learning platform, it's very crucial. Also, data-driven insights, harnessing the power of data analytics to generate real time insights with regard to tracking learner progress, particularly in organization where we have disparate and also multi groups for individual responsible for delivering the service, such as the public healthcare system, leveraging the AI power and the data analytics also power, following and track these individual, very important and very crucial for optimizing the healthcare, the training system for public healthcare workers, actually. Also, we can emphasize the adaptability, the ongoing education, also the importance of knowledge sharing in the previous articulated 2 case studies accordingly. In the final remarks, a quick actionable steps for improvement. Actually, we need to start with the assessment for the current state of public health training system, identify its strength, weaknesses, and area for improvements. And it's very important and crucial to engage stakeholder and collaborate with public healthcare professional and worker, educator, policymaker to gather insights and build a shared vision for optimized training system, develop a training plan that take in consideration the emerging public healthcare challenges and also the guidelines published by organizations such as WHO accordingly, implement innovative training delivery. Again, conventional training methodology prove that it is not a best way in delivering training, particularly for healthcare professionals. So leveraging technology and interactive training methods that enhance engagement, accessibility, and the overall learning experience is preferable. Establish a robust evaluation system for the training initiative. It's very important, and tackling multiple element or aspect of evaluation. Actually, most of the training initiative focus on the reaction level, where also we assess only the satisfaction or the actual reaction of the learner or the trainer after the training itself. In the final remark or conclusion, as we have explored the key pillar of the optimizing public healthcare training system, it's clear that driving excellence will require a holistic, multifaceted approach, and we need to take and actions and the steps to implement this improvement and create a positive impact for the public healthcare system at the national level. In the conclusion, and this is a final two slide with the remarks, training is an investment for all involved in the training itself, whether it is the learner, the organization, the trainers themselves, and also the sponsor of the trainer. The audience and the resources available for the training should be considered at every steps in the process of developing and delivering and evaluating the training in general. When appropriate, make use of existing training resources and activity. Don't reinvent the wheel. Again, most of the institutions currently utilizing publicly available resources and courses published by institutions such as CDC, WHO, public health foundations, and etc. Make use of these resources also make it very effective and efficient, particularly if these particular intervention help the institution in tackling its actual needs. Provide high quality training require time and effort. The quality of the products depend on the quality of the resources actually devoted to producing it. No one can apply every strategy for enhancing training in every training effort. Appropriate strategy will vary depending on the circumstances and also the capability of the organization and the available resources. Training effort can vary effectively and it cannot be a textbook or a perfect scenario for all organization. The perfect is an enemy for the good. The good is actually enough. However, we are seeking to optimize the outcomes of such training initiative. Evaluation is critical. Effective evaluation begin within the training process itself, from the initial phase and up to the evaluation of the actual application of the new knowledge and the skills. Each training activity offers a learning opportunity for the trainers, and we need to tackle a specific competences. Training system should adapt to the changing public health need and continuously update their curriculum to reflect the latest scientific discovered information related to the public health care trend and also emerging threats and public emergencies. I would like to thank you for listening to this actually session for optimizing training system to drive excellence in public health, and also I will leave it to you if you have any questions, please.
Okay, thank you so much, Ala, for the very interesting and informative presentation. Let's give him a big round of applause. So we'll be taking a very short break while we're preparing for the second presentation.
Nak kena mic?
Ada mic ke? Saya mic.
Okay, Assalamualaikum warahmatullahi wabarakatuh and a very good afternoon to all. Yang saya hormati Prof. Roslisa Mana, Prof. Dr. Aidalina binti Mahmud, Dr. Saini Nizam, professors and doctors online and offline, ladies and gentlemen, members of the floor. My name is Muhammad Irfan bin Edros. I'm a candidate for Master of Public Health 2023-2024 UPM. And here I would like just to share a little bit of knowledge and experience regarding international seminar on healthcare financing at UMKT Kalimantan. UMKT stands for Universitas Muhammadiyah Kalimantan Timur. But before we begin, I would like to humbly request for a moment of silence and a moment of peace just to commemorate the passing of my beloved father just exactly 1 week ago, Friday morning on the 14th of June 2024. Let's pray for him. Allahumma ghfir lahu warhamhu wa'afihi wa'fu anhu. Thank you so much. So this is a picture of us, a group photo of us on the very first day of our visit, academic exchange program back in UMKT Kalimantan. We were given the opportunity by the department to embark into this very wonderful exchange program with the university students over there. And we learned a lot of things. And one of the programs that we had was international seminar on health financing in Malaysia and Indonesia, where myself represented UPM to give a little bit of knowledge on healthcare financing in Malaysia. And the second panelist was Mr. Kusnandar. Over there, he is the TPKN Timbalan Pengarah Kesihatan Negeri of Kutai Kartanegara over there. He gave a speech on the health financing in Indonesia as a whole. So it was a hybrid seminar, and you can see that Prof. Aida was online. And then my late father was online as well at that time. And then those are the crowd over there. So this is the part where we're going to start discussing on the healthcare financing in Malaysia itself, which I presented back then with the help of Prof. Aida to prepare this presentation. And towards the end of my CME today, we were going to look a little bit into the healthcare financing in Indonesia. So here's the content of my presentation. So before we look into the healthcare financing, let's just look a little bit on the healthcare system in our country itself. So pre-independence era, of course, there was British colonial rule, and then the hospitals and medical services were provided by colonial administrators and migrant laborers. And then, of course, the Western medical practices were there, and the first medical school was King Edward VII College of Medicine in 1905, and then currently it is the National University of Malaysia. And then in 1880, there was the introduction of the first hospital in Federated Malay States, and it was Yonghua Hospital in Perak. At that time, it was meant to treat the Chinese coolies and also the tin miners for simple ailments like diarrhea, cholera, malaria, and so on. And then the financial support back then was from the Chinese merchants themselves, with the other medical apparatuses and medicines and nursing staff from the state government. And then the fee was low from the face value, 50 cents, but at that time, people could not still afford. And then towards the end of 1880, the state government took over this Yonghua and then turned the name to Taipei General Hospital, like what you can see nowadays. And then post-independence era, of course, there was comprehensive public health system accessible to all citizens approach, all right? And then the formation of the Ministry of Health Malaysia, with the roles of the Ministry of Health in multiple aspects, like provision of healthcare services, policy making, R&Ds, public health emergencies management, and also, last but not least, healthcare financing, which we are going to look into today. All right, and then from 1970s to 1990s, there was expansion and further modernization of our healthcare system, with the focus more on the preventive medicine, okay, with the immunization program, anti-smoking campaigns, and from 2000s to present, we are gearing towards achieving universal health coverage, where we focus more on accessibility, affordability, and also quality healthcare. As we can see here, the fee of the Charge Hospital Kerajaan, or the hospital fee or the clinic fee is still remaining at Ringgit Malaysia 1 or Ringgit Malaysia 5 if you want to look up for specialist review, okay, which is good for us as members of the public, but in the long run, it is detrimental to the health of the economy of Malaysia itself, in which we're going to look into further what our government is planning to do in her white paper, health white paper. So this is health financing mechanism in Malaysia. Before we focus on our country, it is nice to know that in one of the goals of the SDGs is number 3.8 over there. The target was to achieve the universal health coverage. And then by achieving universal health coverage, WHO has appointed 2 indicators to achieve that. Okay, which is the first one, the coverage of essential health services, how far the healthcare service is covering the communities. And then number 2 is the proportion of population with large household expenditures on health, meaning that how much of our population will fall into the category of catastrophic healthcare expenditure, if we may. All right, so those are the 2 indicators by which WHO would monitor how universal health coverage is achieved or not in certain nations. So financing is not uncommon, right, for us, because it is one of the building blocks in what we have learned from the health system building blocks framework by the WHO in 2010. And then this diagram is very nice. It is adapted from Rosita Halina Hussein. This is basically the gist of the healthcare financing mechanism in Malaysia, where we can appreciate that the healthcare service in Malaysia is provided by two sectors, which is the public sector and the private sector. All right, for the public sector, of course, the funding sources coming from government revenue or the budget, the yearly budget that we get, coming from the taxes, and also the SOCSO and EPF contributions, which also will help into the financing of the healthcare in our country, which we're going to look into briefly later on. And then with that money, all right, there will be the purchasing of the services and the products, okay, through line item budgeting, all right, with the intention for universal coverage later on. In contrary, for private sector, the main funding sources would be health care insurance or private insurance, which is, we know that it has its own pushbacks, all right? And then also individual, by individual here, I mean OOP or out-of-pocket payment, which is detrimental as well, which we're going to look into later on. So with this purchasing mechanism of the funding sources for the private sectors, there comes the services over there and charged as fee for service. It depends on what services you're taking. You're going to pay the service as you go, all right? And then of course, they are going to focus on those who can afford to pay, all right? So here's the structure of the Malaysian healthcare system. Again, the summary of it, the public is the main provider, whereas private is the complementary provider. And then the services of the public, of course, is encompassing all sorts of services from public health to clinical services, whereas private, we cannot say that private does not contribute to public health. They contribute to public health as well, especially the function of it is very evident during the COVID-19 pandemic, where we asked their help to help us to take, stable patients to their wards and to their rooms, okay, so that we can, our government hospitals can cater to those more serious patients. All right.
To interrupt for a while.
It's not appearing, is it?
Yeah.
Okay.
Still the same?
Hello, dengar? Baik.
Sekejap.
Teruskan, Okay, terus ganja. All right. So another thing about private healthcare system is very important because it promotes more on medical tourism, which is very famous. Malaysia is very famous for medical tourism, especially in Penang. All right, where we know a handful of visitors, especially from Indonesia and the surrounding nations, coming to Malaysia just to get the treatment at our private sectors. So they play a very important role in flourishing our healthcare system as well. And then the funding and accessibility, of course, the funding comes from general taxation and the yearly budget. And we cannot deny the fact that there is an element of out-of-pocket in our public healthcare system, where our members of public, our people, they have to pay a minimum amount, like 1 ringgit or 5 ringgit. There is an element of OOP, but very minimum. Whereas for private sector, of course, the main mechanism of payment is OOP or insurance, private health insurance. There would always be marriage between public and private healthcare systems, where we call it as PPPs, public-private partnerships, where there are collaborations between both sectors. But still the government regulates the private sector to ensure quality of healthcare and preventing overcharging of the services. So this is how healthcare services in Malaysia are funded. Number one is through governmental funding, which is a taxation. Number two is out-of-pocket payments, OOP. Number three is private health insurance. Number four is EPF. Not EPF per se, but through the withdrawal of a portion of the EPF, which we're going to look into later. And then employee-based health insurances like SOCSO and also SPICPA. And lastly, social health insurance schemes, which are new, which we're going to look into later. All right, so here are the differences of the tax-based funding and OOP payment and insurances. Whereas for tax-based, of course, it's coming from taxes being allocated to the healthcare budget, meaning that it is earmarked for healthcare, all right? And then where the government will manage and distribute this budget. And then for OOP,
Sorry, I have to interrupt again. Sorry for the technical issue. We're trying to rectify this.
But I can hear me?
Yes, they can hear, but the slide is not moving. I'm not so sure.
Tak payah full screen.
Saya full screen.
Stop share second screen. Share second screen.
Tak ada second screen. Tapi buat macam tu, their complaint, it become like the when we're editing.
This one.
Cuba
try share special balik.
Saya baca balik. So,
You buat lah.
soalnya kita share macam ni tadi, same problem. But at least it's moving lah.
Okay kan? Okay kan?
Tak
So
sure.
tengok moving tak? Or
Moving tak slide. Okay. Moving but presenter view.
okay,
Now got a country.
sorry?
Now got a country.
Yeah. Okay, you can read. I'm moving the slide. Moving tak? Moving tak? Okay.
Dia cakap okay?
Boleh. Alright. Okay, kita teruskan. Okay, where were we? Dekat sini lah. Alright, for tax-based funding, of course, the benefit is universal access. Okay, that's the aim of it. And it promotes equity in healthcare. The challenges would be the budget constraints of services, because for now, our government is heavily subsidizing our healthcare system. That's the drawbacks of it. Whereas the OOP, of course, is direct payment coming from the pocket of the patients themselves or the private health insurance. And the benefits would be, it is an option, opt-in, all right? And then people can select what they want, which provider they want. And then the services will be quicker because less people can afford, all right? But the challenges would be expensive. So here's the EPF, another form of healthcare financing in our country, where we know that recently there were the restructuring of the EPF from 2 accounts to 3 accounts. So currently, all of us have those who mencarum, who contribute to KWSP would have account persaraan, account sejahtera, and account flexible. The one which can help in healthcare financing would be account sejahtera, where anyone can withdraw the money in this account sejahtera anytime, but with the reason of healthcare or other reasons like education or takaful protection and so on. All right. There's another financing mechanism, which is Perkeso, which is another scheme for social security. Through this Perkeso, we can see the development of the schemes provided by this Perkeso throughout the recent years, because previously there were no coverage, let's say, for gig workers in the economy, but recently they have this scheme Keselamatan Sosial Pekerjaan Sendiri, those who work in gig economy like Grab drivers and so on, they have the coverage, all right, which is good. Another one is scheme for housewives. They have it right now. So this is a progression in healthcare financing, which we can appreciate nowadays. Another one is SPICPA, which is very common for us who work in a hospital previously, where we know that employers would pay an amount of 120 ringgit per annum to cover up for a 10,000 ringgit coverage of healthcare services in governmental hospital. This is another healthcare financing, but it focuses on the foreign workers. So it is safely say that our healthcare financing in Malaysia is all encompassing. It is inclusive. It includes those who are working. It includes those who are not working. It includes those who work on their own, and also it includes the expatriates and foreign workers. So briefly on the health account frameworks. So we cannot run away from data. So when we talk about financing, there would always be data coming in and coming out. So health account is the tool used to demonstrate how a country's health resources are spent on what services and who pays them, who pays for them, all right? And this captures the flow of the funds in the health system. So for our country, but before that, WHO came up with this, what they call it as SHA, which is System of Health Accounts Framework 2011. So this is like a template or a guidelines for all nations worldwide to look up for when they want to report on their healthcare financing. So we are not left behind, because we have our own Malaysian National Health Accounts, which is known as MNHA, which is very famous in this arena. And then it was established in 2005 under the planning division of MOH, where it produces aggregate health expenditure macro data using estimation methods based on the national and international framework like the SHA by the WHO. Of course, MNHA has their own reports, yes. And then if you dive through the reports, you could appreciate some terminologies like TEH and CHE. TEH is total expenditure on health, and CHE is current health expenditure. For TEH, it will always be above CHE, because TEH, it incorporates the capital spending, it incorporates the money used to build hospitals, to build institutions, the money used for trainings, R&Ds, and so on. Whereas CHE, it does not include those capital building expenses. So TEH is more comprehensive as compared to CHE. But when MNHA would like to report to WHO, MNHA will use CHE because it is worldwide recognized, all right? So there are the key challenges of our healthcare financing mechanism. Of course, number one is funding sustainability, where there would always be push and pull from our government, where to put the money, where to prioritize the money yearly, whether it's going to be on health, whether it's going to be on development, and so on. All right, and also aging population is another issue nowadays, because Malaysia is gearing towards becoming an aged nation by 2030. All right, so of course, with the extension of the lifespan of our people, of course, there would be the expansion of the healthcare or of the care of the health of this pocket of population, right? And then of course there would be rising healthcare costs as well with the advancement of technologies, chronic diseases, increments in the chronic diseases, and also administrative costs. The issue of dichotomous healthcare service delivery, where there is public and private sector nuances, where we know that only 28% of all healthcare facilities in Malaysia are governmental, meaning that it is very few amount of our hospitals and clinics, to compare it with private sectors, where they constitute for about 72% of the total amount of healthcare facilities. Despite that, the outpatient visits in our facilities are doubled, all right, which was 64% as compared to the private, which was just 36%, and this was reported by the NHMS 2019, meaning that our public healthcare services is severely overstretched. So because this overstretching of the healthcare services, we could appreciate that there would be a pool of population going to the public hospitals and clinics with longer waiting times, longer waiting hours, and some of them could not tolerate that, and then they tend to go to the private sectors. Though they don't have enough money, though they are not covered by insurance, they would pay themselves just to get the treatment done right away. So this has caused concern to us, because there would be increment in the OOP spending by our members for the public. So as reported by NHMS 2019, from 2015 to 2019, there was an increment of 5.5% in the number of visits per capita to private outpatient healthcare, to the GPs, all right, by the lowest income quintile group, meaning that even though they are poor, even though they could not afford it, they still go to the private sectors because they had to, all right? And according to the World Bank data 2022, of course, OOP is inefficient and inequitable, as it increases the financial risk for households because they spend more than they have to, all right? And of course, it encourages avoidance of care, meaning that let's say they need care, but they would avoid this because they say that they would have to pay themselves, but they would like to save the money for something else, so they would avoid it. So this is the, the bad side of the OOPs. So here is a very nice diagram brought up by Audun Yemi in 2021. This is called the cycle of impoverishment due to OOP, where the poor household with a sick member, when there is someone who's sick in a poor household, they will seek healthcare or they won't seek healthcare. So if they go to seek healthcare, they will pay on their own, all right? And then there will be less available money for them to spend on other things, all right? So they would be having poorer nutrition and less investment in basic needs. So they will increase in the vulnerability of illnesses, all right, which will increase the poverty level, and then the cycle goes around back again. And then another scenario is that if they don't seek the health care that they need, of course, they would reduce the productivity of them. They will not be able to go to sell whatever nasi lemak, let's say, which will make them less available money for them to spend on the necessity that they have to buy or to pay for, which will later on continue the cycle. So this cycle is detrimental to the health of the people themselves and to the economy of our healthcare system. Another challenge would be expenditure imbalance, where we can appreciate from this graph from 1997 till 2020. It was reported by the MNHA in 2020 that, of course, there are increments in the expenses for both hospitals. The blue one is for hospital, and the orange one is for the clinic expenses. There are increasing expenses. Of course, for the hospital is steeper than that of the clinic. Why it is steeper? Because throughout the years, we could notice more and more NCDs cases with their complications and more needs for longer care, all right? And then also the adoption of technologies and so on. So that's why there's steeper expenses of the public expenditure on hospital rather than clinic. But then here begs the question where how do we strike the balance between giving expenses to hospital and giving expenses to clinic as well? Because there's one thing that we have to look into, which is stepping down of the services, meaning that the services which are usually given at the hospital should be stepped down to the clinics because they can do it at the clinic level, like the management of AGE or URTI, where we are still seeing nowadays that URTI are still managed by the green zones in our hospitals, which is unnecessary to a certain extent, despite the money that they have is a lot more than the clinics, all right? So that is one of the things that we need to look into. So the strategies and solutions by the KKM, of course, preventive healthcare, we should prioritize for that. And also strengthening the primary care, which is a clinic, and of course, which is the expenditure of the clinic should be increased as well. And then the healthcare financing reforms, which is included in our health white paper, which we're going to look into. But before we look into the healthcare white paper, let's look into the introduction to Malaysia health insurance schemes targeted at specific population groups. We know the terminology of My Salam, PKB40, and also Scheme Perubatan Madani. My Salam is more to monetary assistance when there is mishap happen. Okay, like let's say there is hospital allowance, there is let's say there is compasan critical for critical illnesses of 8,000 ringgit. If let's say one is diagnosed with having any critical illnesses, they will get this 8,000 ringgit. So this is for those for B40 income bracket group. All right, that's My Salam. Whereas PKB40 is mainly for NCD screening, all right? Free screening for healthcare and also monetary assistance for appliances, all right? And also cancer treatment and also transportation incentive, all right? Scheme Perubatan Madani is an expansion of that PKB40. For PKB40, actually, it is aimed for those more than 50 years old only. But for a Scheme Perubatan Madani, which was recently established, it is for all, according to your age group. So if you are unmarried and aged 21 years old to 59 years old, you're going to get a coverage of 75 ringgit of treatment at the GPs. If you are, let's say, a single, if you have if there's an elderly more than 6 years old, single, they're going to get 125 ringgit worth of coverage at GP's treatment, all right? Which will cover treatment for acute treatment like minor trauma, headache, AGE, and URTIs, all right? So those are the summary of My Salam, PKB40, Scheme Perubatan Madani, which are seen to be the stepping stone towards a better healthcare financing in our country. So the future direction of our healthcare system, of course, is seen through a health white paper for Malaysia, where the pillar number 3 is focusing on ensuring sustainable and equitable health financing. So this pillar 3 has 3 goals. Okay, number 1, to increase investment for health. Number 2 is to ensure affordable and comprehensive services. And the last one is to ensure effective and efficient healthcare spending. For number 1, I would like to focus on this part where it has 4 proposals for the investment one, but let's focus on this one, which is the reviewing and revision of fee structure at our public sector. The RM1 ringgit and RM5 ringgit is deemed to be looked into and revised for a better future. And then another one is progressive contributory model for health, including targeted assistance and subsidy mechanism, where we know that recently we registered ourselves in PADU system, where we know that PADU is, in the end, it aims for targeted subsidy, according to your B40 or 20, according to your income bracket. So it is not a blanket subsidy for all. So the rich would perhaps get lesser subsidy than the poor group. All right. The second aim is to ensure affordable and comprehensive services. This one I would like to focus on the benefit package. The benefit package, as what we learned, is a package of services according to the needs of the certain group of patients. All right. And then lastly, to ensure effective and efficient healthcare spending, we would like to look into the strategic purchasing, where we would like to see the method of the usage of strategic purchasing rather than the passive purchasing. Passive purchasing meaning that we purchase the services, the products, as we have done it through the previous years. We refer to the previous years and we're going to buy the same thing for the current year. That's passive purchasing, which is not practical because we might not need that currently in this current year. So that here comes strategic purchasing, where we're going to look into the needs, the current needs of the facilities. All right, and then we're going to purchase the items accordingly. That concludes healthcare financing in Malaysia. So I would like to share a little bit on healthcare financing in Indonesia. And then why this picture per se? Because during our visit to Indonesia, we were given the chance to visit Women and Children Hospital called Aisha in Samarinda. And then we were exposed to healthcare financing a little bit in depth by the doctors over there. So what we learned about before that, as we can see here in Indonesia, it is an archipelago of 17,000 plus islands dispersed between Pacific and Indian Oceans. So how vast the country is, so we can expect how difficult it is to manage the country itself. What more to get a better healthcare system in place, all right? Of course, just like Malaysia, Indonesia was also colonized by several colonial, like Portuguese, Dutch, French, British, and Japanese, before gaining their independence in 17th of August 1945, which means that, of course, there would be elements and influence of all of these colonial to the healthcare system in Indonesia. The population of Indonesia to date is 279 million people, and healthcare providers are governmental and private. So in Indonesia, the healthcare system is financed initially through social insurance schemes managed by multiple providers, like PT Askes. They manage for those civil servants and the poor, PT Asabri managing military officers and so on. Because things were not as systematic, so the government introduced in 2014 Jaminan Kesehatan Nasional, which is JKN. So JKN is more or less a compulsory, mandatory national health insurance brought up by the government. BPJS, on the other hand, Badan Penyelenggara Jaminan Sosial, is a social security agency which manages this JKN, all right? So BPJS contracts and pays both public and private providers across the country, though the purchasing policies coming from the government, Ministry of Health. So initially, politicians over there set an ambitious target to sign up all Indonesians and thereby achieving UHC by 2019. So they go by numbers. So in July 2020, it was recorded that 82% of the national population were reported to be participants, meaning that more than 80% is close to 90%. A big portion of Indonesians already signed up for this JKN. But one question emerged from this: does this translate into universal health coverage? Does this number percentage translate into universal health coverage of healthcare system in Indonesia? And taker. Soalan.
Saya boleh jawab sebab saya baca jawapan.
Ada tak? Because so many people already sign up for this. So we can say that majority of them having this health insurance. So it is universal health coverage. Is it easy to say or no? Okay, there's no right and wrong answer, of course, but the thing is, not all facilities participated. Not all private hospitals, not all private clinics participated in this BPJS. Some of them refused because they question the credibility of it. And then, of course, the facilities are not enough. Even in rural areas, people cannot access to healthcare. There's no hospital, there's no clinics in rural areas. So even though they sign up for this, they cannot use it when they want to use it. So there's no UHC per se. So we have to look back into what WHO has put as the indicators, which are two. The first one is the coverage of healthcare system. That's the first indicator of the UHC by the WHO, as I presented earlier. So take-home lesson would be different country would have different financing approaches. It must tailor to the history, the population norms and culture and nature of the current healthcare system. And changes to health financing, of course, like what we are planning to do through our health white paper is, of course, doable, but must be done with caution and proper planning. The other references. So here's a picture of us at Dinas Kesihatan Kaltim, which was the Jabatan Kesihatan Negeri, sort of, in Samarinda. And then here's a nice picture of us with Prof at Posyandu Aster. Posyandu is Pos Pelayanan Terpadu, which means that integrated services. It was a nice one, this one, because Posyandu Aster, the facility is actually contributed by the local people. One local makcik gave this house to make it as a Posyandu, and Posyandu is center for growth and development for kids mainly. All right. So
What does dinas mean?
Dinas means kantor, like jabatan. Jabatan office. Yes. Kaltim is Kalimantan Timur.
Kalimantan.
Yeah. So that's all. This is a picture of
Sorry.
this saja. Ini right. Thank you so much.
Okay, thank you so much, Irfan, for the very interesting and informative presentation. So I will now open the floor for Q&A session. Don't forget to indicate which speaker are you referring to in your question. Oh, very interesting, Dr. Irfan. Sorry, just wondering, could we have a copy of this? Can. Okay, can we repeat? Okay, is there any question?
There is no question, right?
Yeah.
Raise their hand.
Huh? Someone raise your hand. Oh, Muhammad
Raise their hand, I think. Fariha and Haikal.
Macam mana nak tengok? Alamak lah, orang tua lah. Ini macam mana nak? Fikri ya, Muhammad Fikri, Haikal Ahmad Kamai, do you want to ask any question?
Okay, sure. Thank you very much, Dr. For the very insightful presentation. I'm just going to refer to the second presentation lah. I'm attracted to the health white paper, specifically one, I think the first pillar in which you talk about increasing the share of MOH of the Malaysia GDP to 5%. I'm not sure what's the current situation right now in Malaysia. I think it's 3 to 4% of our GDP for MOH. But I guess that's the problem. There are talks that says that we need to increase the GDP first, then we build infra, we build services and whatnot. Then only then we can talk about increasing the fees. The issue of our lifetime right now, the fees, RM1 and also RM5. So I guess my question is, do you think our healthcare system can sustain that long? Meaning that we need to wait for the 5% GDP share, only then we increase the fees? Because I understand that both measures requires political will. It's just that which one needs to be done first? Because if you take 5% of GDP, you're basically taking money from somewhere, right? You're taking money from other ministry, for example. So by increasing the fees, RM1 or RM5, you're taking the money from the public. So which one do you think is the best way to go about it? That's my question. Thank you.
Another question.
Then you raise it.
It's a multi-part approach. I mean, strategic purchasing.
Thank you for the question. Irfan dah buat talian hayat. He dragged me down here. So basically, macam ni, the first thing is the 5% of GDP is an arbitrary figure. Dia sebenarnya WHO there is no documented anywhere that it has to be 5% of the GDP. It was somehow understood by many people that it was 5% of GDP as the best target for allocation for healthcare financing. The percentage depends on the needs of the nation. If your nation is very sickly, not healthy, you need a lot of need, you can increase the percentage more than 5 even. Or maybe your population is already stable, healthy people, you can decrease it below 5%. Or even lower, macam tu. So if we were to take the 5% now at this point, not yet 5, we want to increase it to 5. That's one approach lah. Like I agree with Irfan was telling me, it's a multi-pronged approach. That's true. The 5% of GDP ni, dia bergantung. It depends on the income of the country lah. Not necessarily we take it from other ministries and it will orang kata lessen the money for other ministries. It's a bit more complicated than that lah. And then like Irfan said just now also, the fact that it is a multi-pronged approach, meaning that other methods or approaches needs to be done as well. For example, you need to do strategic purchasing, lean management, and good strategic planning dan sebagainya for the penjimatan. It's either we increase our revenue or we make I'm taking Prosite punya thoughts juga lah ya. Dia kata is either we increase our modal, capital revenue, atau whatever that we have now, kalau itu tak boleh buat, if we can't do that now, whatever that we have right now, we have to make sure it's as lean as possible lah. No wastage, very efficient, cost effective and stuff like that. So like I said in the class kan, kalau jawab economics ni dia kata no right or wrong answer. So Fikri, I hope that's okay. Any other questions?
Prof, can I have Prof?
Allah. Siapa pula?
So question.
Yeah.
Actually, during the other day, when I attend the talk.
Yes.
In Bank Negara, they said the 5% is not actually contributed by the government alone.
Betul.
It can be partly from private.
Correct.
With the government, so it's total up to 5%.
To 5%.
So it's not just not just from the contribution from the government.
Betul.
So they said one of the option, if you really wanted for the government to contribute to 5%, is to introduce tax reform.
Betul. I super agree with that, tax reform. Because like you say, the 5% of healthcare spending in the country, as you say, dia bukan, like I said just now, 5% of course is an arbitrary number, but let's say we hang on to 5 is actually total spending lah. And like you say, government and private. Masalahnya if government stays as is now, and then therefore that implies that private needs to do something. Private means not only, ialah kita lah, out of pocket spending dan sebagainya kan. So anyway, I also attended a conference by EPF, and there was this gentleman from University Malaya was talking about reforming our tax lah. So he was into GST. Long story lah. This one can take 3 nights and 3 days when you talk. So anyway, something for you guys to think about, because you will be the pelapis, the seconders of my generation. Nanti think about it, how to improve on the health orang kata service ni, delivery, because at present state the care is getting more and more expensive. People live longer and longer and longer kan, and when you live longer, we tend to, if we age healthily, okay, the thing is most of us don't age healthily. Sebab there's a study done, it's not the old, kan kita kata aging population mahal, it's expensive kan, kita going towards aging population, our healthcare akan mahal dan sebagainya. Yes and no, there was a study done yang mengatakan bahawa it's not the aging process per se yang increase the cost, it's the cost of dying. If you have lots of children and they're all sick with cancer, for example, that is costly. So it's not but you have a healthy 90-year-old happily going around, tak semahal, not as expensive as a sickly a 10-year-old, for example. Kan? So we as public health need to go into that lah, healthy aging. That's the thing we have to go. Aging tu dah tak boleh nak, we can't really stop that lah, because all of us tak macam mana kan, we are living longer, but it's our duty as public health to make sure they age healthily. The cost of dying is more expensive sebenarnya. And I mean the cost of dying and the cost of illness yang chronic ni. Okay, thank you very much. Anything else? Tak ada? Soalan dia macam ni. Tak ada soalan lagi kan? Dia kan, ada soalan lagi? Tak ada soalan lagi kan? Okay, I think we should call it a day. It has been a long week for most of you. So thank you very much for those online and also here. We'll meet again next time, insyaAllah. Assalamualaikum. Maafkan segala kekurangan. Terima kasih atas perhatian. Thank you. Macam mana nak tutup jalan ni? Ada orang ke? Allah raise hand. Gadis satu. PM tepi sorry. PM tepi. Okay lah. Adam pun kata dekat. Kau jangan. Adam. Adam ni babai.
Doktor.
Babai. Allah. Tadi kata.
Tak ada. Salah emoji.
Tutup